Your mic is not on.
Good evening, sir. Sir, my
Good
topic
evening.
is about diastolic dysfunction and cardiac output monitoring, sir. Uh, what is the first we will discuss about the diastolic dysfunction. What is diastolic dysfunction? The diastolic dysfunction is nothing but of the impaired left ventricular relaxation or increased stiffness leads to elevated filling pressure despite preserved ejection fraction. It is very common in elderly, hypertensive, diabetic, and patients with ischemic heart disease. The anesthetic management is challenging due to its sensitivity to heart rate, rhythm, preload, and afterload. Perioperative morbidity and mortality are increased, making the vigilant monitoring and management is essential. The classification of diastolic dysfunction, according to the echocardiographic grading, it has 4 grades. The grade 1 is nothing but of impaired relaxation, where E bar A ratio is less than 1 and it has normal LA pressures. And grade 2 is pseudo normal, where it is E by A ratio is 1 or 2 and it has elevated left atrial pressures. Grade 3 is reversible and restrictive, but in which EA ratio is more than 2 and it decreases with Valsalva maneuver. Grade 4 is irreversible and restrictive. It has fixed E, e bar A ratio is more than 2 and it has poor prognosis. Pathophysiology. Due to impaired relaxation, it leads to increased left ventricle in diastolic pressure and it causes pulmonary venous constriction. And it depends upon the atrial contraction, that is atrial kick, and it leads to the loss of atrial systole and which is poorly tolerated. In tachycardia, it leads to decreased diastolic time and leads to increased left ventricular end diastolic pressure and pulmonary edema. In bradycardia, it leads to decreased cardiac output. In hypovolemia, it leads to decreased preload and decreases stroke volume, and which leads to decreased cardiac output. In hypervolemia, it leads to pulmonary congestion and edema. What is the perioperative assessment and optimization in the patients with diastolic dysfunction? We need to have a detailed history about the patient having dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and the patient has comorbidities like long-standing diabetic, hypertensive, coronary artery disease, atrial fibrillation. We need to investigate this patients with this history, echocardiogram with EA ratio, LA mass, LA size, and LV mass. And we need if BNP or NT-proBNP is available. In ECG, we will have left ventricular hypertrophy, AF, and ischemic changes. The optimization before the surgery, we have to control BP, heart rate, rhythm, and optimize glycemia, and we have to treat ischemia. Drugs in this normally the patients with diastolic dysfunction will be started with beta blockers, AC inhibitors, ARB, and diuretics. Anesthetics gold in the patients with diastolic dysfunction. We need to maintain sinus arrhythmia, avoid tachycardia, avoid hypotension, maintain normovolumia, preserve afterload. Intraoperative monitoring in diastolic dysfunction. In induction, we need to have smooth, slow, titrated induction. Ethambutol or titrated propofol is used. Opioids, fentanyl or fentanyl to blunt sympathetic response. Avoid ketamine as it increases the heart rate and oxygen demand. Maintenance, volatile anesthetics, sevoflurane or desflurane are used in low concentration. Balanced anesthesia with opiates and muscle relaxants. Avoid myocardial depressant drugs in excess. Monitoring, we need to have standard ASA monitoring, invasive arterial pressure monitoring, and central venous pressure has been limited utility. Fluids, we have to give a restrictive and small influence of fluids guided by advanced monitoring. Vasopressors are preferred over fluids for hypotension. Emergence should be smooth and controlled. Avoid tachycardia and hypertension. Postoperative management. The patient with diastolic dysfunction, the patient should be monitoring in ICU or HDU in high-risk patient category. strict fluid balance and diuretics if necessary. Early, sorry sir, current got off. Uh, Early resumption of antihypertensive and beta blockers and antiarrhythmetics. Good analgesia, epidural or nerve blocks with caution to avoid hypotension. Vigilance for pulmonary edema, arrhythmias, and myocardial ischemia. Cardiac output monitoring. It is importance in which guides in giving fluid therapy, vasopressor use, and goal directed management. Helps in avoid fluid overload and critical in diastolic dysfunction. Modalities. There are 4 modalities. First one is a non-invasive methods, bioimpedance, bioreductance, limited in accuracy in unstable patients. Second one is the pulmonary artery catheter. It is a gold standard and it is used in by thermodilution method. It provides cardiac output, stroke volume, systemic vascular resistance, and filling pressure. It's invasive associated with its complication, useful in severe cardiac dysfunction and in major cardiac surgeries. Second one is the transesophageal echocardiography. It's a dynamic real-time assessment of ventricular filling, relaxation, wall motion, and ischemia. Can measure diastolic measures, E-body ratio intraoperatively. Extremely value in high-risk cardiac surgeries. Minimally invasive monitoring, such as flow track, LIDCO, PICCO, analyzes the atrial waveforms. It provides the cardiac output, stroke volume variation, pulse pressure variation, limitations in abnormal ventricular compliance and arrhythmias. In goal directed therapy, it titrates the fluids and vasoactive drugs based on the real time cardiac output and stroke volume data. Improves outcome in high risk surgery by optimizing perfusion without overload. Thank you, sir.
So you have finished both the topics. Okay. So can you classify what is the cause of diastolic dysfunction?
Sir, what is that?
Cause of diastolic dysfunction.
Sir, mainly it commonly in elderly people, sir. It increases with age and hypertensive, diabetic, and patients with ischemic heart diseases, sir.
Right. Ischemia. That is the main reason. Answer is it is an indication of ischemia. When the heart starts to fail to relax, it is an indication of ischemia, and the coupling does not get uncoupled. The actin myosin complex which goes into the muscle contraction, it does not get released uh, at the same fast by the reuptake of calcium into the uh, sarcoplasmic reticulum. That is the main pathology that happens in diastolic dysfunction. And how is it classified? You said it is the severity is classified according to grade 1, grade 2, grade 3. Is
Yes,
there
sir.
any other classification of diastolic dysfunction you have read about? You said it will cause pulmonary congestion, it will cause stasis and all these things. So what will be the result of constant pulmonary congestion or overload on the pulmonary circulation?
It leads to pulmonary edema, sir.
Pulmonary hypertension. First,
Pulmonary
it will not
hypertension.
directly go to pulmonary edema. It will cause first pulmonary hypertension. So the
Okay,
current concept is diastolic dysfunction is classified into two categories. One with pulmonary edema and other with other no pulmonary edema. So
Okay,
patients with no pulmonary edema have a better prognosis than patients who suffer from pulmonary edema, pulmonary hypertension. So
Okay.
the echo or the invasive methods by which you have to assess the pulmonary pressures, and if it is more than 30 millimeters, then it carries a higher risk than the patients who have a normal pulmonary artery pressure. So, and another important, as I said earlier, the current concept of treatment of this diastolic failure is to use the SGLT2 as a cardiac remodeling therapy, which is approved by the FDA in patients who, even without patients with not having no diabetes also. So that is the current concept which has to be included in the answer. So I'll just share my